Next in our agenda, we are welcoming 3 of our faculty members to present their research findings from studies that I hope give us a glimpse into some of the broad areas of primary care and education research in our department. So each presentation will be about 10 minutes, followed by 5 minutes for questions. And as you've seen, there's microphone on either side. So towards the end of the talk, feel free to line up. So first up, we have Dr. Abhimanyusud, whose study is entitled Late-Breaking Results from the Meditate Trial in Improving Depression in People Living with Chronic Pain in Primary Care and Beyond. Dr. Sood is an assistant professor in the DFCM, research chair in primary care and population health systems at Humber River Hospital, and chief scientific officer in the Chronic Pain Center of Excellence for Canadian Veterans. Using a paradigm of clinical population medicine, his research and implementation projects focus primarily on the complex intersection of chronic pain, mental health, and opioid use, something I think so many of us see every day. He uses a variety of research methods to investigate this area, including clinical trials, systematic reviews, implementation evaluations, and bibliometric and media analysis. He also conducts evaluative education research under the theme of understanding the relationship between educational methodology, program outcomes, and health policy. So welcome, Abby.
Okay, good morning, everyone. Change of gears. You're going from the national leader in public health and family medicine to the stuffy researcher whose biggest accomplishment was fitting into his pre-pandemic dress clothes this morning. Something we can all relate to, I guess. So I'll be reporting, this is very exciting, reporting on the Meditate trial, trying to find ways to improve depression for people living in chronic pain, one of these big population health problems. I have no commercial interests, any disclosure of commercial interests to declare. Particular shout out to the support from the department as a researcher, which has enabled the research I'll be reporting on today. And really, on the theme of community, it really does take a village. We had our analysis meeting about this project last week, and we were joking that we have almost as many co-investigators and collaborators as we had research participants in the trial. But this has been, because of the twists and turns that I'll talk about a little bit from the pandemic, this enabled a lot of collaboration and community building across the department. So particular shout out to DFCM faculty, many are here, Michelle, Deanna, Michelle Namer, I haven't seen her yet, Rahim, Andrew, Leon, and of course Ross as the co-principal investigator. And this project was funded from a grant, an operating grant from the Canadian Institutes of Health Research. So as a bit of background, we estimate that 19–20% of Canadians across the lifespan live with chronic pain. Estimates, if we believe the numbers, are as high as 60% of people living with chronic pain live with comorbid mental illness, including depression, anxiety, post-traumatic stress disorder. And people who are living with this comorbidity use healthcare resources at a much higher rate than their colleagues, their peers who are living with chronic pain, or the people who are not living with chronic pain. We prescribe opioids at a higher rate, much more likely to develop substance use disorders, much more likely to have experience an opioid overdose, and much more likely to actually complete suicide. So poor overall health outcomes for people who are living with this comorbidity. And if we add those numbers up, we're talking about somewhere close to 10% of our population here. But there are some major challenges with applying depression guidance in chronic pain. And I took this image, this is from about 2 years ago, maybe 3 years ago now, from the BC floods. If we recall that, I know everybody's timelines are hazy from the pandemic. But I think this represents both the lived experience of chronic pain and depression, and also our experience as healthcare providers trying to provide care. It's sort of coming at us from both sides. You see that overlap of symptomatology between chronic pain and depression and mental illness. And our guidance and our path forward is obscured, right? We know we have to do something, but where do we go? What do we do? Our signposts are flooded. So we had to actually pause our trial, and I'll get to that in a moment. So what we decided to do was actually do a systematic review, trying to understand what is the existing guidance, what is the existing available evidence for treating this comorbidity. And I think this is a very telling example of where we have been. This is one of the few national clinical practice guidelines for chronic pain anywhere. You see it's about 10 years old now. But it's one of the only ones that actually has a specific statement around management of depression and chronic pain. And if you look at that guidance statement, you'll know it cites a single RCT. If you look at that RCT, so a single RCT informing a guidance statement. Okay, if you look at that RCT, it was a trial looking at optimizing antidepressant therapy and a 12-week self-management program. But then you look at the guidance statement. The guidance statement is optimized antidepressant therapy. Optimizing antidepressant therapy should be considered for the treatment of patients with chronic pain. So our sort of evidence informing system for this comorbidity is somewhat broken. So we did an umbrella review looking at all the systematic reviews reporting on outcomes for people living with depression and chronic pain. You're not meant to interpret that. That's just to show where the kinds of interventions we saw. So we saw things like a lot of psychological interventions, mind-body interventions like yoga, tai chi, meditation, exercise interventions, pharmacological interventions. This is actually a network diagram. So there are very few, you can see very few comparative studies of pharmacological interventions against any of the other kinds of interventions. So this is a forest plot. I'll just very quickly run you through this. So basically, each row is a different kind of intervention. You see that middle line here, anything around there is basically no or trivial effect. If it's to the right, it's actually a harm, worsening outcomes. To the left, where we see most of the systematic reviews we're reporting, is an improvement of effects. Now, in each row, if you're towards the top, that's a higher quality systematic review. So we're looking for interventions kind of in this area, the top left of each, and you see that's pretty blank. So we had to change our criteria, and we found basically a few interventions: fluoxetine, web-delivered psychological interventions, and acceptance and commitment therapy as ones that met certain thresholds for we can have some confidence that they are effective for improving depression and chronic pain out of this whole world of possible interventions. So our evidence is somewhat thin. So that's why we came up with Meditate. And I should call out my colleague who's not here, Michelle Nelson, who came up with the name Meditate, Meditation for Improving Depression and Opioid Use in Chronic Pain. My suggested acronym when we were submitting this to CIHR was mediocre. That didn't make the cut, and I'm thankful for that, because probably I wouldn't be here talking about this trial because it wouldn't have gotten funded. So what we did is compare a meditation intervention that had prior evidence for efficacy for treating treatment-resistant depression in elderly people, which was our initial target audience, against an active control. This is called the Health Enhancement Program, which has been designed specifically as a control for things like being a part of a group, learning new things, which are actually really important parts of improving depressive symptoms in people, regardless of whether they have chronic pain. And sort of more importantly, we were trying to think of this from a sort of health system perspective of how can we better leverage community resources together with formal healthcare. Often when we think about mind-body interventions in healthcare, it becomes sort of medicalized or professionalized, where us as health professionals become the people who are delivering the intervention. And there are good reasons to do that. I mean, we have the trust of our patients, we have the trust of our communities, but we also have a lot of other skills that can be deployed elsewhere. And we have other people in the community who have even probably greater expertise than we do in delivering these kinds of interventions like meditation. And so the idea was, how do we, and let's study this connection between community and formal healthcare in community healthcare settings to see if we can amplify the effects, because we want to address this issue at a population health level, not just at a local clinical level. So our primary outcomes were depressive symptoms using a scale of PHQ-9. We had secondary outcomes of improvement of pain and pain interference, and then some exploratory outcomes in terms of health-related quality of life and opioid use. I'm going to focus on the primary outcome because that's what we've been able to analyze so far. We're still collecting data for the trial. We had to totally change the trial because of COVID-19. We started recruiting in 2019. Our first cohort was going to run March 13th, 2020. So you clearly know what happened. None of the interventions had ever been delivered virtually before. We didn't have approval from any of the organizations that were delivering to be able to deliver them virtually. So we were on pause and hiatus, and everybody knows the story from there. But what we were able to do is we were able to pivot to online delivery about a year later. We adapted the eligibility criteria based on feedback from the participating sites to understand how best can this research inform actual practice. And we had to actually revise our data collection methods to move everything virtual, everything online, which we didn't really have much precedent for, but we said, what the hell, let's go for it. And we were able to expand the number of recruitment sites. And I think that's where DFCM really comes in. We started just with one community chronic pain site. We were able to expand to include Sinai, Women's College, Toronto Rehab, St. Mike's, the Chiropractic College. We see a lot of people in pain who have comorbid mental illness, and Michael Garon. Ultimately, we actually had a lot of people referred, 510 people referred, 147 were screened. We enrolled 108, and they were randomized to the two arms. Ultimately, we had data from about between 60 and 70, depending on how we analyzed the data. So quite an accomplishment, given all the challenges that we faced. So not mediocre, I'll say that. And we're still collecting data, as I mentioned. So we've just got data. I'll be reporting data from our primary outcome, which is just a few weeks post intervention. So these are just some of the demographic information. I'll point out specifically about 85% of the participants were women. This is very much reflective of the larger literature of trials in chronic pain. Not reflective of the epidemiology of chronic pain, but somewhat reflective of the population of people living with chronic pain who present to healthcare. Unadjusted PHQ-9 was 15, which is right in the middle of, so our inclusion criteria was basically 10 to 19, which is moderate depressive symptoms. So right in the middle there. So for our primary outcome, what we found was for our active arm, which is the meditation group SSM, which you see on the left there, was an improvement of 3.62, and I'll interpret that for you for a second, in a second. And also the standardized mean difference was 0.7. So those are bolded because what's considered the minimally clinically important difference on the PHQ-9 is 3. So we were able to demonstrate that this intervention was able to result in, on average, across the population, in a clinically important difference for our participants. Likewise, standardized mean difference, if we go, we'll go back to that slide in a moment, is considered a moderate effect size. So if we go back to this slide, remember we had our fluoxetine, our psychological web-based interventions, ACT, and this is about where the Meditate trial would land. Okay, obviously, it's a small trial. It's not coming from a systematic review, so we have to keep that in mind. But performs about as well as some of our other interventions that we would deploy. And I think that's the key point here. I haven't reported, including the slides, the other outcomes: health-related quality of life, pain, and what we see. The signal all is improvements in those outcomes. Now, the trial is not powered to show significant outcomes along those secondary significant effects along those secondary outcomes, but we see the directionalities all in the right direction. People are getting better and getting a benefit from this intervention. And importantly, also no adverse effects were identified during the trial. We didn't see huge differences between the two arms. And this is really a major challenge for those of you who are mental health researchers or users of the literature. We know that really a lot of interventions, if you give education, if you put people in a group, even showing videos to people about nutrition, for people living in depression, their depression scores will get better. So it's very hard to show an improvement compared to an active control. We also know, this is the first time these interventions have been delivered virtually, so it's sort of an unknown, and we have to do that work of comparing what they look like, the effects compare to in-person delivery. We've had major effects, of course, of mental health, but from the pandemic, during which this trial was conducted. I mean, we had stories of people who, during the intervention, they had family members dying. You can imagine what impact that's going to have on their PHQ-9 during the course of a trial. So really our next steps, of course, we have to complete our data collection, which is going to be our long-term outcome. And we're also doing an implementation evaluation, which is really trying to understand how do we make these kinds of interventions work in day-to-day practice in primary care. And of course, that's where the feedback from all of you is going to be very helpful. So we know it's a safe and effective intervention, at least over the short term. And there may be some opportunities for integration into routine practice. And perhaps we can do something like a pragmatic trial potentially in our department to understand how we can make these kinds of interventions work and work better for the patients that we care for. Thank you.
Wants to go up to the mics?
Yeah. Hello, I am Anne Birchall from St. Michael's Hospital. Congratulations on a very interesting trial and a really important topic. I was wondering, particularly thinking about implementation, could you talk a little bit more about the intervention itself, compliance, any dropout issues? Looks like you were having an effect, but
yeah,
how was that?
Great question. So the intervention is really three consecutive days, about 2 hours per day, where they're introduced to a very simple, easy to practice meditation intervention that's delivered in the community already very widely, either for health purposes or not for health purposes, just for improvement of quality of life. And then there was a follow-up on a weekly basis, about a 1 hour follow-up. They learn a practice that they can do on a daily basis. We keep a log. We kept a log of whether people practiced or didn't practice. Of course, we'll be able to analyze by that sort of dose effect of the intervention. And yeah, the dropouts or participation rates were about equal between both arms. This is also a challenge with trials of this nature where people, and one reason that people argue for waitlist controls is that people will drop out if they don't get the active arm. And so that's a challenge that we've been facing in some other trials that we're running using similar kinds of intervention, not the exact same intervention, have actually moved to a waitlist control. Obviously, that introduces other kinds of issues, in terms of interpretation and analytically, but it's such a hard question about what the right sort of what the right comparator is. And I think it also goes to like, what are we trying to answer with these kinds of questions? Because our traditional mode is often, does this intervention work? And what about it specifically works? Is it the meditation part that works? Is it the group effect that works? Is it the learning something that works? And I think we also need a shift of understanding. We know that these things, I mean, if you go back to the force plot, there's a lot of things that do potentially work, but we don't make good use of them in our system. And I think understanding how we can make better use and make these kinds of interventions available, as long as they have some evidence for efficacy and good, robust evidence for safety, is sort of the implementation side. Didn't have a chance to report on that yet in the 10 minutes that we had. Thanks.
How do you keep people going doing this after the trial ends?
A really good question. There's a couple other trials that have looked at this intervention, and actually they've been able to demonstrate that regardless of whether people continue with the intervention, they continue to have effects. So this is a trial looking at that I'm thinking about right now about mind-body interventions for improving PTSD amongst veterans. And regardless, and they did that analysis, it was a large trial, we're able to demonstrate that regardless of whether people continue to practice the intervention or not, they had significant effects even 1 year out, which is very rare for behavioral intervention. I think community is also the other important part. These are group-based interventions. People are more likely to continue with them and engage with them if they feel like they are a part of a community. And then so being able to, outside of a trial environment, we can't do that in the trial, but outside in a real world setting, I think we'd want to be able to continue to connect people to community where they're learning these interventions.
Thank you so much.
Thank you.
So next, I'd like to invite up Dr. Giovanna Siriani, who will be presenting her education research study entitled A Program Evaluation of the Family Medicine and Enhanced Skills, also known as FAMES, Integrated Residency Program Pilot. Dr. Siriani has worked as a family physician with a focused practice in palliative care at Sunnybrook Health Sciences Center for the last 16 years. At the DFCM, she holds the roles of Enhanced Skills Program Director and Faculty Development Lead for the Division of Palliative Care. Dr. Siriani's academic interests include supporting learner competence via excellent instructional methods and learner assessment. She has made it a career commitment to support the implementation of competency-based medical education in both undergraduate and postgraduate programs to ensure that learners are practice ready. Dr. Siriani has been engaged in education scholarship and research to help impact the larger medical education community by sharing lessons learned via peer review. Dr. Siriani's work has been published and presented both nationally and internationally. Among other publications, her writing has been featured in Medical Teacher, Canadian Family Physician, and the Globe and Mail. She is also the co-creator of the About Empathy podcast, an educational tool for health professions learners. Welcome, Giovanna.
Thanks, Allison, for that introduction, and it's nice to see so many friendly faces. So I'm thrilled to present our team's work today. In terms of my disclosures, this work has been funded through educational grants at the DFCM. I've been the recipient of grants from nonprofit organizations, and I don't have any affiliations with for-profit entities. In terms of conflict of interest, I'm one of the co-authors of this study, and as Enhanced Skills Program Director, I'm one of the organizers for the FAMES program. So by way of background, in Canada, the College of Family Physicians, as we heard, and many of you will be familiar, has opted to begin the process of expanding to a 3-year postgraduate training program. Sorry about that. To support the provision of comprehensive longitudinal primary care, especially in the context of an aging population with medically complex needs and fewer early career family physicians opting to provide comprehensive care. An additional factor in Canadian family medicine training is the option for current residents to complete a 3rd year in an enhanced skills area of interest. Sorry, I'm having trouble with the slides. Oh, sure, thank you. So considering this national conversation around transitioning to a 3-year family medicine residency program and an increased interest in enhanced skills training, the University of Toronto postgraduate program began to explore the concept of an integrated 3-year clinical residency program as a future curricular model. This internal conversation actually predated the determination by the college that there should be an enhancement of their learning outcomes with a subsequent shift to a 3-year residency. So really our team's conversation about an integrated clinical program has now dovetailed with the shifting landscape of postgraduate training in family medicine. So next slide. So the team designed the Family Medicine Enhanced Skills or FAMES pilot to integrate enhanced skills training in either palliative care or care of the elderly into years 2 and 3 of family medicine postgraduate training. And the design is meant to support longitudinal and integrated enhanced skills experiences while also maintaining resident exposure to the patient medical home model of care and comprehensive family medicine. So next slide. The aim of this study was to evaluate the implementation of FAMES in its first iteration. So this was our pilot introduction to the program. And attention to program implementation is really critical given evidence across the education spectrum about the elusiveness of sustained, scaled up curricular reform. And so the study was viewed through the lens of normalization process theory, or NPT, which helps structure our data. So using a four-part framework, NPT really explores the work that's done to standardize or normalize a program of practice beyond the early stages of implementation. So the following constructs: collective action, reflexive monitoring, coherence, and cognitive participation describe distinct ways in which a practice can be operationalized. So collective action really refers to how people work together within a given program and what the division of labor is that's needed to allocate roles and responsibilities. Reflexive monitoring really involves looking back at the program to see what can be improved, which in turn helps to ensure sustainability of the program. Coherence is the work and thought that individuals put into understanding and internalizing the aims of a new program. And finally, cognitive participation is the work that people do to build and continue a community of practice around a new program. So our evaluation questions included, number one, in what ways do faculty teaching practices and resident learning practices reflect or adapt core principles of the curriculum? And what are the perceptions of key stakeholders regarding the sustainability of the new program? So we used a descriptive multi-case study approach to evaluate the FAMES program. Documents outlining the FAMES design and implementation were collected for a holistic understanding of the program. The planning documents and review of those documents provided insight into ways in which the enacted program might have differed from the initial curriculum design. In addition, we had semi-structured interviews, and these were conducted with participants that ranged from our residents, program directors, site directors, faculty, and administrators. In total, 22 interviews took place between June 2021 and June 2022. In addition to the key stakeholders, the 2 residents in the program were interviewed in both rounds to evaluate their perception of FAMES. The transcripts were imported into NVivo, and then thematic analysis was employed. So in reviewing our data, 4 main themes were identified through this lens of NPT. So one was, we saw that collective action occurred, and that helped support normalization of the program. In terms of reflexive monitoring, feedback during the pilot program helped to inform on-the-ground program modifications and future iterations. In terms of coherence, we noted that there was variable internalization of program values. And as it pertained to cognitive participation, we made note of relational work that occurred among participants to help sustain the curricular intervention. So I'm going to go into that in a little bit more detail. So collective action. So our participants reflected that collective action did occur to support normalization. So for example, our residents felt well supported by the administrators, site directors, and program directors in the initial phases of the program as processes and experience were being established. And this was found to be a buffer against the uncertainty that they felt as the inaugural residents in the pilot program. So in terms of reflexive monitoring, so evaluation and adaptation occurred to help make the curriculum sustainable. So reflections were made about program structure, processes, and resourcing. Participants expressed an interest in additional program modifications to optimize integration across both years of the program, which led to curricular changes. Participants also wondered about how best to resource an integrated residency program. So although administrators in our study didn't perceive undue burden on their time with this small cohort size, concerns were expressed about the ability to scale up a program of this type, especially if managing both integrated and standard stream residents. Administrative limitations were noted in terms of our current assessment platform, and that impacted the ability of our site directors and program directors to view rotation assessments in a timely manner, and that required new solutions to help ensure that the standard system that we have would be accessible. In terms of coherence, so our data revealed a contrast with internalization of the values of the program. So there were mixed reactions to the program's goals, with most individuals that we met with supporting the concept of integration as helpful, while others resisted the idea that early integration is beneficial to supporting professional identity formation in comprehensive family medicine. Residents and faculty both felt that this integrated approach to curricular planning helped support and drive the development of adaptive expertise through early introduction of a focused area of interest. This was supported through the need to balance both family medicine and enhanced skills clinical experiences within rotations, but also across longitudinal experiences. The importance of ongoing family medicine longitudinal clinical experiences in the third year was also emphasized by the participants as a key program component. And then finally, in terms of cognitive participation, here we go. Finally, there was relational work around participation in the program to help sustain the curricular intervention. So for example, residents took on a leadership role within their clinical experiences to explain this novel program and help faculty preceptors better understand their unique learning needs and level. From the faculty perspective, when they better understood the stage of training and expectations for the integrated residents, they were able to tailor learning experiences accordingly. From the residents' perspective, they did note some drawbacks in terms of feeling isolated from their peer group due to the small cohort size. So this was despite attempts to support them both at their sites and in the Enhanced Skills program. So finally, to wrap up in terms of our discussion, so this pilot program evaluation of an integrated 3-year program showed promising results in terms of supporting the skills needed for adaptive expertise. Although this current iteration of the pilot was deemed sustainable, questions arose about how an expanded program could be resourced and supported. Program implementation or program modifications were implemented as the pilot evolved to meet the emerging needs and feedback of key stakeholders. This included modifying the organization of the curriculum to better meet the learning level of the integrated program residents and adapting our assessment system. And this data has helped inform our current FAMES structure and program, and we hope that it will inform future iterations of the program. So in terms of next steps that will inform further program development, include determining which enhanced skills programs are well suited to this curricular approach, implementation with a larger cohort of residents, and securing resources for expansion. And the insight gained from examining this evaluation will contribute to developing and integrating larger scale curricular innovations locally and at the national level. And then finally, probably the most important thing that I wanted to mention are the acknowledgements, because to put together a program of this type, to study it and implement it involves a huge group of people. And so thanks to Dr. Betty Onyura and Shruti, who helped us around our study design, methods, and results. Acknowledgements to thank you, Danielle. Acknowledgements to our larger postgraduate team who helped us not only with implementation of FAMES, but also with securing an Art of the Possible grant for the work. And then finally, thank you to the residents who joined our FAMES program pilot, the site directors who were involved in the first iteration of the program, our program directors, our administrators, and the faculty, those of you out there who have worked with the residents. And without this larger group, the pilot wouldn't have been possible. So thank you for your attention, and I'm happy to answer any questions you might have.
Thanks, Giovanna. Mahan Kulasekaram, Director of the OES. This is fantastic work. It's unfortunate Lawrence couldn't be here to hear this. I really think that he should see the presentation. I'm really curious, we're embarking on the 3-year program pilot. What do you think the CFPC needs to hear about this work that might inform their thinking about integrating enhanced skills? And maybe a second question is, you sort of alluded to the fact that maybe not all enhanced skills might lend themselves to this model. What makes you think that might be the case? What might be the criterion or deciding factors for that?
Thanks, Mohan. So in terms of your first question, I think from the CFPC's perspective, what I would like to hear is an openness to the role of enhanced skills within a 3-year program. Because I think if we hear their messaging at this point, it's enhanced skills will not be part of the 3-year program. That's the college's messaging. They're saying it will be a 3-year program. And then if there's an interest in enhanced skills, it'll be in addition to the 3 years, so a +1. So I think that there should be an openness to considering how we can design a curriculum that involves enhanced skills. And I think it speaks to your second part of the question, or your second question about what can the design of a 3-year program look like, or what types of program might be well suited to that. There is a variety of enhanced skills programs out there. Just at U of T, we have the largest program in the country. We have 17 enhanced skills programs. And I think many of them, if we think about low risk obstetrics, for example, elements of taking care of global health and vulnerable populations, much of what the college is aiming to do with a 3-year program can be, I think, woven in with the opportunity to integrate perhaps a stream of enhanced skills focus in the 3 years. So I think there are opportunities there. I think we have to think very carefully about which programs are well suited to that and not. When I think about programs like family practice anesthesia, for example, that's very procedurally driven, perhaps that type of program might not be well suited to a 3-year integrated approach, but I think others will be. And I think that's the work of our group. And I think that's the work we need to take on nationally. So thank you, Mohan. Erin.
Hi, I'm Erin Burst, family doctor at Sinai. I might have missed it, but you talked a little bit about how the integrated program helps people to sort of initiate and foster their love of this area of specialized practice. And, you know, obviously through the program, it facilitates that ongoing comprehensive care. Are you following the residents now beyond to see if they continue that comprehensive care versus the narrowing in? Because I think that's always the fear for us,
Right.
is that people develop these areas of focused, thank you, practice, and then move away from comprehensive family medicine, which of course both are needed. I respect everybody that has focused practice, but how do we keep them doing both?
I think that's a great question, Erin. I think we're just in the initial phases of the program, very few residents, because we haven't to date had the resources to have this be more expanded and then look at how residents then are practicing prospectively. So I think that's something we want to look at in the future. We only had 2 residents graduate, and we have 2 residents graduating in June. So it's a little, I think, too soon to say. And I think when I think about this, I don't think about it as a panacea or a, yes, this is the solution, because we know that the decisions that people make about practice are complex in nature. I think about this as creating the curricular conditions that can support that. And hopefully, as we think about expanding the program, we can look prospectively to see what people's career choices are. And thank you.
Thank you so much, Shivana. So for our final research presentation, I'd like to welcome Dr. Deborah Butt to present her study entitled Patient Visits and Prescriptions. It's going to sneak for ADHD from 2017 to 2021, a retrospective cohort study. Dr. Deborah Butt is an associate professor, clinician investigator, and utopian clinician scientist in the DFCM. She also works as a family physician in a community-based practice in Scarborough. Dr. Butt has extensive experience and expertise in the use of primary care EMR data and using administrative data for research and evaluation. Welcome.
Good morning, everyone. It's certainly a pleasure to be invited here to give a talk on a topic that is underrepresented and understudied in primary care. You'll notice in the first slide that I've mentioned, there's a bit of an echo. Is that because I'm too close? Okay. You'll notice in the first slide that there are other co-investigators mentioned. And this study certainly would not have been possible without having a wonderful team. And I just wanted to thank them today. And I wanted to inform everyone that this study was recently published. So it just goes to show how coming together research teams and like-minded people in research can certainly achieve a lot using utopian data. So in terms of disclosure, I am a research scholar with the DFCM. I've been a research scholar, and I'm kind of embarrassed to say this, since 2002. I thought, oh, I don't feel that old, but hey, that's a long time. I also am supported by the Rathlen Foundation Primary Care Electronic Medical Record and Foundation Fund. And that certainly would not have been possible without the great efforts of Dr. Karen Tu. This study was supported by an operating grant from the Canadian Institutes of Health Research. And by way of background, and this is important because I am looking retrospectively, you know, we all remember what happened on March 17th, 2020, where Ontario declared a state of emergency due to the COVID-19 pandemic. And that from March 14th, 2020 to May 15th, 2021, Ontario schools and educational institutions were closed for at least 20 weeks. And this was much longer than any other Canadian province or territory. Canada had the longest duration of primary and secondary school closures at 51 weeks. From February 4th, 2020 to February 8th, 2022. And that's only second to the United States in comparison to the list of G10 countries. Canada was also the only country in the G10 list of countries to have a fairly restricted internal movement. And that included cancellation of public events, public gatherings, education, and workplace closures, as well as a ban on international travel that began in the spring of 2020. So what does this create? These multiple lockdowns and social isolation that we've experienced, you know, as in the general population, because we had to change the way we do things. Remote educational learning, working from home was all new, and it impacted the mental health of the general population, but it really impacted those with underlying attention disorders. So there are several studies that were published on how the COVID-19 pandemic impacted patients of all ages with ADHD. And I'm just going to, you know, highlight some of the key studies from across the world, the US, Canada, just to show how around us this was a problem. And this is largely how this study came about, because as a family physician in practice, we were observing that there seemed to be an increase in the number of patients presenting with concerns about ADHD. They were coming to us during the COVID pandemic. So then we decided as a team to do a study where we looked at family medicine practices in Ontario to examine the trend of patient visits and prescriptions for ADHD specific medications prior to the pandemic from 2017 to 2019, and then during the pandemic from 2020 to 2021. So the objective was, we saw an increase. That was an observation that we saw in family medicine, but we weren't sure if the increase was the result of a greater number of patients that were presenting with ADHD related concerns. In other words, was it an increased patient prevalence? And or was it an increase in the number of visits that we were seeing per patient, where they were presenting with a concern related to ADHD as the most responsible reason for the visit in the primary care physician's office. And that's more reflective of an increased health service use. So we conducted a longitudinal study of family medicine practices at the University of Toronto, Practice-Based Research Network, Utopian, from January 1st, 2017 to December 31st, 2021. The Utopian Data Safe Haven, which we are all familiar with, is a large primary care EMR database with records that are collected from family physician practices in the Greater Toronto Area and beyond in Ontario, Canada. And we selected the age range as our study population of those 5 to 55 years of age, because when we looked at visits and prescriptions outside of this age range, they were very low. So just in terms of the characteristics of the utopian data safe haven, it involves a contribution of EMR data from 14 of the DFCM affiliated sites. It represents about 400 family medicine clinics with over 100 family physicians that contribute their EMR data, and represents about 500,000 patients, and that number continues to change as they continue to recruit. And it also has involved 3 EMR vendors. So the outcome measures that we were interested in for this study was looking at the total number of patients with at least one OHIP billing code with the diagnostic code for ADHD, which is the code 314. We also were interested in the total number of patients that presented with at least one prescription for an ADHD specific medication. And the other thing that we were interested in was just looking at the total number of visits that were related to ADHD as a measure of service demand on the healthcare system. So in terms of our analysis, we used a repeated cross-sectional design to describe the annual visit and patient prevalence rates from January 1st, 2017 to December 31st, 2021. So data from the years before the pandemic, 2017 to 2019, were used to predict the expected rates during the pandemic for 2020 and 2021. And we also looked at Poisson regression. It was used to estimate the expected count. I'm going to start with 2. So we looked at the total number of patients with at least one ADHD related visit. We looked at the total number of patients with at least one ADHD specific medication. And then we looked at the total number of visits related to ADHD care. So what were our findings? Well, what did we find in primary care? Well, in terms of the total number of patients that met our inclusion criteria per year, it was about 266,208. And that's the advantage when you have a large database like Utopian. That was our eligible pool. And we saw that from 2017 to 2021, the numbers, were relatively consistent. We saw that the annual rate of ADHD visits increased from 3.7 visits per 1,000 patients in 2017 to 10.5 visits per 1,000 patients in 2021. We saw that male patients had higher rates of ADHD compared to females at 13.4 versus 8.1 per 1,000 patients in 2021. We also saw that patients residing in higher income quintiles had higher rates of ADHD visits than those residing in lowest income quintiles. And that was 13.2 versus 6.6 per 1,000 patients in 2021. So when we look in figure 1 at the expected and observed trends in ADHD visit prevalence during the COVID-19 pandemic, the y-axis reflects the ADHD visit prevalence per 1,000 patients. And we looked at the annual rates per year from 2017 to 2021. And the red dots represent observed, and the blue dots represent expected. And what did we see? We saw that the number of unique patients with at least one visit for ADHD related concerns remained consistent with pre-pandemic trends. But we can see that those trends were increasing. In figure 2, when we look at the expected and the observed trends in ADHD prescription prevalence during the COVID-19 pandemic, we see that the prescription rates observed during the COVID-19 pandemic were within the expected range during during 2020 and 2021. What we also see here is that prescription rates for ADHD specific medications are increasing on an annual basis. And in figure 3, when we look at the expected and observed trends in ADHD visit rates during the COVID-19 pandemic, the y-axis is the total visit rate, we saw a significant difference in 2021. What we saw was that there was a 32% overall relative increase in the total number of visits to family physicians for ADHD amongst those aged 5 to 55 years of age in Ontario compared to the pre-pandemic period from 2017 to 2019. When we look at 2021, we looked at that year, we saw that there were more frequent visits to family physicians for ADHD-related concerns among specific groups, females in particular. When we compared what we saw during the COVID pandemic to pre-pandemic period, we saw that females in the age group 5 to 9, particularly those 20 to 24 years of age, as well as the older adult females, visited their family physicians more frequently regarding a concern related to ADHD. We also saw that in males in the age group 25 to 34 years of age, that this also happened in that particular age group. So in terms of conclusion, the number of patients visiting for ADHD-related concerns in the primary care setting and being prescribed medication at least once yearly increased as expected in 2020, 2021 compared to pre-pandemic levels. We also saw an increase in the intensity of health service use in the primary care setting. And this was observed for those living with ADHD symptoms. So people living with ADHD symptoms were experiencing more difficulties. And this is reflected in an increased demand on family physicians to spend more time addressing concerns related to ADHD in 2021. So as we continue living with the pandemic, this study suggests that resources to support family physicians may be needed. So that concludes my presentation, and I welcome questions.
Hi, Deborah.
Hi, Eva.
Congratulations. And I think it's a great study to show the power of utopian. I'm just interested in knowing whether or not you were able to look at virtual versus in-person with respect to visit rates.
Yeah, we were not able to, I mean, this study combined virtual and in person, and we did not separate it into that analysis. But in terms of our findings and just, speaking in terms of the data, it may be that the frequency in visits from the same patient was facilitated because of the uptake of virtual care in terms rather than in person, because we have published studies using utopian data in which we did see that we were doing less periodic health exams, we were doing less physicals, we were doing less well baby checks, but we were doing a lot of more visits for anxiety and depression with our virtual care. So that still remains to be looked at, but I do believe that Karen is looking at that in a grant that we were able to obtain, and so the results should be forthcoming.
Hi, Dr. Buck. Thank you very much for sharing your study with us. I was wondering if you could maybe expand on some of the ideas that you might have about the supports for family physicians that might be necessary as one of your conclusions for the study.
Sure. In my days during medical school training, there wasn't very much taught about diagnosing and managing attention deficit disorders. And a patient with attention deficit disorder, whether from childhood to adulthood, and oftentimes they are missed in adulthood, but if we look at a child and we see the impact on that child as that child grows, from an educational point of view, to a social point of view, through an occupational point of view, and also children with ADHD have at least 40 to 90% have at least one comorbid condition. So it's quite impactful, it's quite significant. And given that the significance of this, family physicians need some type of integrated care pathway to help care for these patients. To make a diagnosis cannot be done in a typical 15-minute encounter. We need time, we need multiple visits to make this diagnosis, and we need adequate training, if not that, but at least the support. And that support should include psychoeducational assessments. We know that for our patients, and whether we've had to face this on a personal level, psychoeducational assessments are very important in helping those children to learn. But oftentimes the wait lists for these are very long, and if patients, and I mean, at least a year is unacceptable, because during that time, they can develop other comorbid conditions as a result of not having that support. As family physicians, our resources are to look at private services, which a lot of our patients may not be able to afford. So we are facing significant challenges in managing this condition in primary care. And that is the reason why I've made a transition in focus in trying to raise awareness of this condition using primary care so that we can advocate on a policy level to ensure that children and adults are getting the support that they need. So there is work to be done.